I'm moderating. Oh, that's fine. Don't you? It's 1 o'clock, and so I think we'll go ahead and start right on time because we have a very full program today. I'm Glenn Solomon. I'm the chair of internal medicine and neurology at Wright State University Boonshoff School of Medicine, and it is my distinct pleasure to welcome everyone today to our first COVID-19 vaccines symposium. It is my heartfelt prayer that this will not need to be an annual symposium and that we will get COVID-19 under control and not have to do this on a yearly basis. I firstly want to thank the COVID-19 vaccine task force for their incredible hard work in putting this program together. This program has come together over a period of just about 4 or 5 weeks. And I'm going to leave it to Dr. Hussain when she speaks to talk about the task force. But I want to thank the members of the task force and all of the other folks who have been so supportive in helping make this program happen. Just a few housekeeping notes to get us started. First, this program is being recorded, I hope. So I hope Sarah is busy recording this program. It does say recording in the top, so I guess we are recording this program. So just so everybody knows, we are recording this program and it will be posted on the Boonshoff School of Medicine webpage, I believe on the Facebook page, and hopefully also on the Department of Internal Medicine webpage as well. If we can put it back up, there is a QR pre-survey that we would like everyone to fill out the survey before the symposium, and there will be a post-symposium survey as well, and we'll have a slide for that at about 3 o'clock. So again, if we can get everybody to use their cell phones and go on to the link and do the pre-survey, that's much appreciated. If people have questions for the speakers or for our distinguished panel during the program, if you would be kind enough to chat those specifically to me, Glenn Solomon. That way, all the other folks who are participating and watching don't have to be bothered by the chats popping up at the bottom of their screens during the talk. So again, any questions that you might have for the speakers or for the panel, please chat them to Glenn Solomon. And at the end, when we get to the panel discussion, we will go through as many questions as we can. We are not going to interrupt the speakers or do questions and answers between talks because again, we are on a pretty tight schedule and we have a number of people who are coming to us from outside who are going to be joining us. And so we will hold the questions to the end. But if you send them to me, we will make sure that we have them to go through for the panel discussion afterwards. With that all having been said, it is my great pleasure to start the symposium, and I would like to introduce our first speaker. Dr. Valerie Weber is the new Dean of the Boonshoff School of Medicine. She's been with us since the beginning of November, and it is my pleasure to welcome her to give our introduction.
Thank you so much, Dr. Solomon. I am Valerie Weber. I'm Dean of the Boonshoff School of Medicine. And on behalf of the whole School of Medicine, I'd like to extend a warm welcome to all of our participants today. I'm really so proud of the student and faculty leadership and the community support that's really made this event possible. I'd like to give a special welcome to Governor DeWine and Mayor Whaley for being with us today. We all know what a difficult time this past year has been due to the pandemic. Pretty much every facet of our lives has been disrupted. Over 24 million Americans have been stricken ill with the virus. And by the end of today, we will likely reach the sad benchmark of 400,000 American deaths. Around the world, there have been over 2 million deaths, but hope is on the way. In a record-setting period of time, not just one, but 2 vaccines have been developed and received emergency approval by the FDA, and now are being distributed to at-risk populations, and more are on the way. We in the medical and scientific community are so proud of these developments, but we're also really concerned about our ability to deliver these life-saving vaccines in a timely way. This is a challenge of unparalleled magnitude. Today's event is really so important in delivering information to the medical community to help with uptake and help with vaccine hesitancy in our community. So I'm really proud and pleased that we can help in this effort and hopefully increase patients and the public's understanding of the benefits of the available vaccines. So thank you very much for your attendance, and I'm looking forward to an illuminating event today.
Thank you, Dean Weber. It was great to have you here, and it is my great pleasure next to introduce Governor Mike DeWine, Governor of the state of Ohio. Thank you, Governor, for taking the time to join us in our program today.
Dr. Solomon, thank you.
I was going to make the point that for those who don't know you as governor, they may know you as the sidekick of Amy Acton.
That'd work. Doctor, thank you very much. Thanks everyone for tuning in. I looked at the agenda. It looks like a very packed afternoon, and appreciate you being on. Appreciate what everyone does to take care of our Ohio citizens. You know, this really is the time that we've been waiting for, the time that we could go on the offense. We've been playing defense for about 9 months or so, and with the vaccine here, even in a limited quantity, it feels good to be on the offense and moving forward. So we're very, very, very happy about that. Today is kind of a landmark day for us because we start with 80-year-olds, anyone 80 and over, which of course is the highest risk population that we have. Our goals as we roll out this vaccine really are threefold. And eventually, of course, the goal is to get everyone in Ohio who wants the vaccine to be able to be vaccinated. And that's the ultimate goal. But we know that that will take a number of months, that there is limited supply. So with the limited supply in mind, we really have 3 goals. One is to save lives. 2 is to get our kids back in school by March 1. And the third is to protect our health workers, men and women who are out there protecting us each and every day. And so everything that when we make a decision about how we prioritize this, it's really driven by those 3 things. We had a conversation. I had the opportunity to have a conversation on Sunday with General Perna, just to really try to get an understanding of where this rollout is going and what we can expect in the weeks ahead. So the next several weeks, we do not really expect much change in the vaccine that we're getting every single week. It is going to remain, we think, fairly steady. In a few weeks, it's going to tick up a little bit, but we probably don't see a major change until the Johnson & Johnson vaccine comes on the market. So I don't know when that's going to be. Some people have estimated mid-March, but that will be a significant change as we move forward because that is one dose instead of 2. The Pfizer and Moderna are 2 doses, either 3 or 4 weeks apart. And so being able to just give 1 dose, to add that to these and have 3 different vaccines in the United States, in Ohio, will be, we think, a big deal. Let me talk a little bit about the saving lives and how we've gone about that. Over 50% of all the deaths in Ohio have come out of Ohio nursing homes. We have, I think, 970 nursing homes in the state of Ohio. So we have a lot of nursing homes in Ohio, and we've seen real tragedy there for obvious reasons. Congregate care setting, they're living too close together, and individuals who are older generally, and individuals who may be medically challenged. So vaccinating the nursing homes was a top priority. And the good news is we have completed that. I think we've completed every nursing home in Ohio. Of 970, I think they're all done except 4 where they had problems getting in. They had to hold up because of the COVID being in there. But virtually every nursing home done, and a lot of nursing homes are now in the process of getting the second vaccine. So we're getting good uptake from the residents. We'd like to get 100%, but we're getting pretty good up. The first time through, I think it was 85 or 90%. The health workers, people who work there, that was a lot less. That was about 40% the first time going through. But so the good news is we're through there. We're moving on to the second dose, and then we're moving to some assisted livings, which we've already started as well. So a very vulnerable population. What we start today is those 80 years of age or older. And I know that you've all seen the statistics, but I had my team just run it again yesterday. And if you want to see where you protect Ohioans, I'll start really at the oldest group, 80 plus. 53% of our deaths have been from those 80 years of age and older. If you go to the group 75 to 79, it's 14% of our deaths. 70 to 74, it's almost 12% of our deaths. And then 65 to 69, 8% of our deaths. And it begins to drop off from there. 60 to 64 is 5%. 50 to 59 is 2%. And then it really drops below the age of 50. So we're starting with our oldest group, and it is, I think it's going, what we can see at least so far today, it's going well. We still have the limited vaccine continues to present challenges. For example, just taking the group 80 and older, today, this week, we hope to vaccinate about 100,000. And that's the vaccine that we have out available for those 80 years of age and older. That group in Ohio, though, 80 years of age and older who live outside congregate care settings, who live out in the community, that's about 425,000. So you can see the challenge as we move forward with this limit. It's going to take a while even to get the 80 years of age and older. As we move forward, we're going to move down in age and continue to go down. So everything we're doing, really, protecting the health workers and then getting our kids back in school. And let me talk for a moment about why that's important. We have had some kids, particularly kids in some of our urban schools, have been out of school all year. Teachers are trying to do a good job, doing a good job. Students are studying, but this remote learning for some students does not work very well. And we hear this from teachers, we hear this from other educators, parents. And so getting kids back in school is a very significant objective. And we know the way to do that is, frankly, to be able to vaccinate the adults in the schools and to give them confidence that they can, in fact, go back. So that is, I said, a separate goal. Protecting our medical community that's out there in the front line is important to protect them. It's the right thing to do, but it's also important for our community to be able to have those medical professionals continue to be on the job and doing what they do each and every day. Everything else we're going to be doing is really driven by the data and trying to figure out, who the most vulnerable people are. We have a fragile group, those 65 and under, that we'll be announcing and talking about today. But by and large, the data clearly shows in Ohio and across the country that the best way to measure this and the most effective way to pinpoint who's the most vulnerable is age. That age is by far the most important indicator. And that's why we are starting with our oldest group and then moving down as we go forward. So thank you very much. I just wanted to give maybe kind of an overview from my perspective as we look at this. But I want to thank you for your work, what everyone does. We have so many different partners out there. For example, this week we have over 700 places in Ohio that will be receiving this vaccine, either today, some started yesterday, some today, some tomorrow, some Thursday. And these will be pharmacies, these will be hospitals, these will be health departments, these will be clinics, some private practitioners, and they're the ones who are going to be delivering this vaccine in the weeks ahead. So again, thank you for allowing me to jump on here and kind of get this started. I know you're going to have a good day. Again, many thanks.
Thank you, Governor. We really appreciate you taking the time out of your busy schedule, and we greatly appreciate your tremendous leadership during this pandemic. So again, on behalf of all the healthcare professionals, thank you again.
Thank you very much.
Our next presenter will be Dr. Weam Hussain. Dr. Hussain is a third-year internal medicine resident at the Wright State University Internal Medicine residency program. She is a graduate of the Boonshoff School of Medicine and heads up our COVID-19 task force. And this whole project was really her brainchild. And so it is my great privilege to invite Dr. Hussain to speak to us.
Thank you, Dr. Solomon, for the kind introduction. I will share my screen with everybody. So it's my great privilege to talk about our COVID-19 vaccine task force today. I'm sponsored by Wright State University, Boonshoff School of Medicine, Department of Internal Medicine and Urology. So our task force members in the fall of last year, with news about the upcoming COVID-19 vaccines, many patients have been sharing concerns and questions about the new vaccines. We wanted to find a way to give back and serve our local community in these confusing times with the massive amount of information that's confusing and difficult to grasp. So we created a task force with the 7 medical professionals listed here, where we could, as a team, provide resources and help address any concerns or questions about the COVID-19 vaccines. So this is our agenda for today. Dr. Solomon is our wonderful moderator. We've heard from Dr. Weber, Dean of our Boonshoff School of Medicine, and Ohio updates from our Governor, Mike DeWine. So we will continue our program on a variety of topics that will be addressed by a diverse panel of medical professionals, followed by a live Q&A session by doctors of various specialties. So what are the objectives of our task force? First and foremost, to collect accurate information about the COVID-19 vaccines as approved by the FDA. We want to understand the side effects, compare vaccines, review trials, and fact-check information with rampant misinformation in the public about the new COVID-19 vaccines. Second, to create educational materials for awareness about the vaccines. And third, to disseminate information to the Dayton medical community and our local community members via virtual meetings, the news, and social media platforms. So physician offices are being flooded with calls by patients, whether they should receive the COVID-19 vaccine or not. If the physician states that the patient should receive vaccination, it carries significant impact versus hearing information via news outlets or other sources. If medical professionals are up to date with information effectively trickles down from provider to patient. We also have come to hear that some medical professionals are themselves not convinced about obtaining the new vaccines. And so this seminar opens up avenues to share concerns and any questions that they may have. So we're excited to share this information today. Thank you for this opportunity to share information about our task force.
Thanks, William. Our next speaker is Dr. Median Ali. Dr. Ali is the medical director of the intensive care unit at Sycamore Medical Center, and he will be speaking with us on the COVID-19 virology and management.
Thank you so much for this opportunity. I just want to make sure if you guys able to see the slides and just hear me okay. Can I just do that as a test? Can you hear me and see the slides?
We can see your slides and hear you just fine. Thank you.
Excellent. Thank you so much. I'd like to thank Wright State University, Boonshoft Medical School, and Dr. Solomon, Dr. Weber, and a special thanks to Dr. Wiam Hussein and Sarah for really hardworking on making this happening. My job today is to highlight some of the connection between the structure of the virus and the development of the vaccine. Maybe talk a little bit about why we all need to be vaccinated, making the case for vaccination. If we start looking at the virus structure, as you can see here, in the center of the virus, there is the RNA, the genomic material. Now, luckily, we actually were able to get the map of the genetic material of the virus back in January of last year, and we were able to analyze it and figure out the genetic sequence of the S spikes, and so we were able to get the mRNA vaccine started. As you can see, it's covered by protein shell to protect it. On the top of the protein shell, there is the envelope. This envelope, which is a fatty tissue, a fatty layer to protect the genomic material. And on the top, you can see the S spikes. And these S spikes, as you can see, these are what give the coronavirus its name. And also, it does help the virus to get into the cells. So this is really important part of the virus. Now, these S spikes, as you can see them here, they come together. Each spike has about 1,273 amino acids, and there are 26 spikes, trimers on each virus. And the S spikes has three different domains. The domain that is very important is the one that responsible to be attached to the angiotensin converting enzyme receptors. The way that the virus gets inside the cell is by the S spikes attaching to these receptors. Let's show you here how that happens. So let's talk about the life cycle of the virus inside the host cells. So when you get infected with COVID-19, the virus takes its way from your upper respiratory tract to the cells. It attaches to the ACE2 receptor. Through the fusion process, it gets in, and then it releases the RNA. The RNA would hijack your ribosomes and will start making copies of the RNA itself and copies of different particles, different parts of the virus, such as E protein, M protein, S protein, etc. And then all of that virus particles would go to the Golgi bodies and then eventually reassembled and get out of the cells. I'm going to show you here again how that happened. So as you can see here, the virus is attaching to the ACE2 receptors. By being able to attach to the ACE2 receptor, it's actually allowing it to get inside the cells. Remember that there is a fatty layer on the virus, there is a fatty layer on the cells. Each of them has a negative charge. So the virus cannot get inside the cell. It has to find a mechanism to attack and to attach, and that mechanism through the S spikes and the ACE2 receptor. Now, after that happened, the virus would be able to get inside the cell, as you can see here, and then takes its way, and then it releases the RNA. As you can see here, the RNA of the virus is released, and it starts making copies of the RNA through the ribosomes and translates into different parts of the virus, like M protein, E protein, etc. And then all of these particles will go to the Golgi bodies and reassemble together into another virus that would be able eventually to exit the cells. And then eventually the cell, unfortunately, due to all this invasion, will be destroyed. So we talked about the pathophysiology of the virus, how it enters the cell. You know, when you actually talk about vaccine, the vaccine actually, we try the mRNA vaccine, they try to copy the virus to some degree. So after they figure out the genetic map of the virus, especially the genetic sequence of the S spike, the scientists of Moderna and Pfizer, what they did, they encoded that message in mRNA. What you see here is the messenger RNA here. That's a messenger RNA. Now, they put that message, please go ahead and make us S spikes. To deliver that message to the cell, it's very difficult really because mRNA is a protein, it will be destroyed. So what they did, they surrounded the mRNA with fat particles, nanoparticles. These are the fat particles that protect the vaccine, protect the mRNA from being destroyed before it gets into the cells. And if you actually have allergy to the vaccine, you're actually allergic to these particles, not to the mRNA. So now the vaccine, the mRNA is able to go inside the cells. And after it go inside the cells, all these fatty particles will go away, will be destroyed. And the mRNA will go to the ribosome and start making copies of itself. Start making, sending the message to make S spikes. So the message is clear, make S spikes. And the reason we are making S spikes because we want to induce immune response from the body. So now the S spikes are produced, the body would react by producing, antibodies. And you're gonna see in a second, these antibodies being produced. You see here the reaction. So now the body is producing antibodies and T cells are activated. There is B cell, memory B cells also activated. So next time you get a real infection, you already prepared. Now, let's say this is the virus attacking you right now. Now you have all these antibodies that were recruited already and ready to bind to the S spike. They are ready, they are binding to the S spikes. And as they bind to the S spikes, the S spike now cannot attach to the ACE2 receptors. And if the virus cannot enter your cells, cannot replicate, it will die, it will disappear. And that is the principle of the mRNA vaccine that we are giving right now. So my next few slides gonna be focusing on making the case why we need to be vaccinated. Why is COVID-19 such a threat? And I'll go over all these 8 points one by one. Number 1 point, this is actually a pandemic that is different from other pandemic. It's actually, there is a silent transmission, and that silent transmission is responsible for almost 60% of the cases. Think about it, people, gathering for fun, for love, or whatever, they are giving diseases to the others. They are actually giving death. And that, I don't remember this happening at this large scale, at least in the modern history. So this disease is different, for example, from Ebola. Ebola, when you get sick, you have symptoms, you stay home. This one, you could actually have no symptoms and you go for whatever activities and you could spread the disease. 59% of all transmission came from people without symptoms. 35% of these people may not have symptoms when they infect other people, and they, for 24%, may not have symptoms at all. Remember, you are most infectious 2 days prior to the symptoms and 2 days after symptoms. So most people may not be aware when they go to work or to activities that they don't have symptoms. And that is the primary reason we are focusing on social distancing and mask. And actually for short term, these will be more effective in reducing the cases than the vaccine itself. Now, the other thing why we need to be vaccinated, it is fatal disease. It's the third leading cause of death in year 2020. It is causing, so far it caused about almost 400,000 deaths in the United States. This is from January 17th, so this is probably a little bit behind, and we have about 24 million cases in the United States. The fatality rate is about 1.7% in the United States. Around the world, there are, I think there are about 95 million cases with about 2 million deaths so far. So probably we're very close, maybe we're a little bit better than the rest of the world, but some countries have it up to almost 8.6%. Now, is it like any other, like a flu or pneumonia? No, it's different. And I can show you here, if you look at the graphic in the bottom of the slide, you can see the blue line is the influenza, the red line, I'm sorry, the blue line is COVID-19 and the red line is influenza. And as you can see, between age 18 to 40, there is not much difference death-wise between COVID-19 and influenza. But as you go above age 50 to 60, 70, 90, you see a huge difference. You see like a death rate, 35%, for example, above age 80 for COVID-19 compared with less than maybe 5 or 6% for influenza. So definitely it's different. Also, like with influenza, we have some therapeutic. COVID-19, we really don't have effective therapy. And our immune system was exposed to the influenza, so we do have some degree of immunity compared with COVID-19. The other problem we face with COVID-19, and as a pulmonologist, I see, unfortunately, very frequently now in my clinic, is what you call long COVID, you know, or like post-COVID-19 syndrome. And I think that's going to be probably a problem we may have to deal with it for years to come, even if the virus hopefully disappears in the future. It's more common in women than men. Average age is about 45 years. One study actually showed only 1 in 8 was completely free of symptoms after 2 months. Another study showed 2/3 of the patients experienced symptoms, most commonly shortness of breath, even 2 months after the infection with COVID-19. There is a Chinese study actually showed after 6 months that fatigue, cognitive dysfunction, and malaise were common in these patients. There are reports about mental health issues such as anxiety, depression, hopelessness, and PTSD. In my practice, I see really now, unfortunately, really significant number of these patients coming back. You know, we celebrated that they got better. They came outside the ICU, outside the hospital, went back home. But then, to know they come back after 2 months, 3 months, they are still on a little bit of oxygen. They are still short of breath. So I think we will have probably maybe hundreds of thousands of people that have the after effect of COVID-19 for many years to come. So I want you also to be aware that this is actually not just a respiratory virus. It's not a lung disease. It's actually multi-systemic disease. And that's something we see in the ICU all the times. We see people come with COVID-19 pneumonia, they progress to ARDS. We see elevated troponin, which reflects myocarditis, elevated creatinine, which could be from ATN, or it could be sometimes actually a direct effect of the virus. We actually have been seeing a lot of encephalopathy, delirium, ICU delirium, encephalopathy. These patients actually require, in general, higher level of sedation, and they do require also a prolonged hospital course, prolonged ICU stay because of the ICU delirium and encephalopathy associated with COVID-19. The other thing you guys hear about it frequently, thromboembolic disease. Unfortunately, we have a lot of cases also of PE, DVT, sudden death associated with COVID-19. There is some controversy about whether you should anticoagulate them, even if you don't have evidence in the CAT scan of PE or DVT. That's still controversial. We will talk about that separately. And in kids, we know there are some cases, luckily not many, but some cases of multi-system inflammatory syndrome in children, which is reaction, more like an immune reaction to COVID-19. So we talked about the viral factors. Now we're going to talk about the host factors. You know, we are not prepared this pandemic on many levels, but mostly we're really an unhealthy nation. I mean, just to admit that, there is a survey just published recently, 73% of American adults are either overweight or obese. 45%, more than 45% of US adults are at increased risk of complication from COVID-19 because of chronic conditions. And about 19% of them, they have 2 or more chronic conditions, which actually increase the risk for COVID-19 by much. And we're not talking about elderly. You know, we're about 53% of those at greater risk for complications were less than 60 years of age. So some people promoted herd immunity as a way to obviously natural infection, herd immunity as a way to get over this pandemic. This is obviously not practical and not ethical. If you look, for example, at areas like New York City, the percentage of seropositive for antibodies was only 25%. To achieve herd immunity, you need anywhere between 70 to 90%. So you need probably 3 times this number. That means we have to have 3 times the cases and 3 times the death. We already projected to have 500,000 deaths by mid-February. I don't think like 1.5 million would be a good idea. And obviously, reaching the luckily right now we have the vaccine, and hoping with the vaccine will not only provide you with the herd immunity eventually, but actually would provide with longer duration immunity and stronger immunity than the natural infection. The other thing, I think we are in a race with the virus itself. So, you know, remember you heard about the UK variant B117, which has 23 mutations, as you can see there, that different from the earliest version, and that started in China. The problem is, you know, is not the mutation. Actually, viruses have a lot of mutations. That's actually part of their life. And the reason they have mutations because they really, you saw the replication, it's really sloppy process. So it's filled with mistakes because it's a sloppy process, it's fast process. So mutations happened with coronavirus, with the novel coronavirus. It does not happen at fast rate like the flu. But the problem, the virus now affecting, you know, millions and millions of people. So it gives it a chance to have more random mutations. And the more random mutations, the higher chance that you may have some of these mutations causing a real change in the virus, especially in the affinity of the S spikes to the ACE2 receptors. The more that S spikes is sticky and able to attach to the ACE2 receptors, the more infectious is the virus. And that's what we've been seeing in the UK variant, in the South African variant. We know that there is Ohio one, there is California one. So the longer that goes on, the higher the chance the virus would eventually be more resistant to the vaccine. We know so far, at least the UK variant is not resistant to the Pfizer vaccine, because that test was done, and luckily it's still effective. The other point I'm going to make, you know, what makes that a threat and makes vaccination important is the fact that, you know, many politicians and others politicize the pandemic. They politicize mask wearing, public health messages, even therapeutics such as hydroxychloroquine. We are flooded with the misinformation, you know, about the vaccine, about the disease, about whether it exists. I mean, we had patients dying in our ICU, and they still believe it was not real. The thing that really, honestly, out of all of that, was, you know, hurting the most is because of the psychic numbing. The fact that we see 3,000, 4,000. We reached actually almost 4,400 deaths a day, and the public reaction, our reaction, is not there, and that's getting used to this number of deaths is something, you know, it's difficult to live with, to see that number of deaths in our ICUs, and you know, you feel like helpless, you feel like you can't really help your patient. It's really like a very, very painful experience that myself, our staff all went through. This is a very busy slide. I apologize for that, but if I thought put everything in one slide so you guys can share it. If you want to look at treatment in one slide, I'm going to divide it in a couple of slides. So the bottom line for treatment of COVID-19, we really don't have effective treatment. Whatever you hear, whatever you see, there are some good promising treatment. There are treatment that would decrease the number of days in the hospital, progression of the disease. There are treatment maybe like steroid would decrease mortality, but we don't have a treatment that is game changer. If you are outside the hospital, you have a mild to moderate symptoms, quarantine, take Tylenol, drink fluid, just rest. There's no effective treatment. Now, if you have a high risk, if you are one of the high risk group, like our governor talked about nursing home patients, for example, these patients should really be referred to have their monoclonal antibodies infusion. People above age, for example, 65, 70 with diabetes, hypertension, heart disease, these people should be referred to the monoclonal infusion center for treatment. Please don't give dexamethasone for people who are outside the hospital and not requiring oxygen. It does not work, and sometimes there are reports of harm. For hospitalized patients who are not on oxygen, there is no indication for steroid as well. Sometimes we test everyone in the hospital, obviously, and sometimes some of them would test positive. There is no need to give them steroid. Using remdesivir in these patients without needing oxygen, kind of controversial. In our institution, we don't use it. Now, if you are hospitalized patient on oxygen, then yes, go ahead and give remdesivir and give dexamethasone. If the patient gets better, you don't have to finish the remdesivir course. Dexamethasone is 6 milligram daily for 10 days, oral or IV. Now, if the patient is hospitalized and on high oxygen, like high flow oxygen or BiPAP, non-invasive ventilation, you can give the dexamethasone, but the remdesivir may not work as good. So you can give it still, but it's not going to be as effective. Remember, remdesivir is antiviral, it's anti-replication. You have to give it early when the virus is doing the replication that we showed you with the video. If the virus is done with the replication and now it's more the inflammatory reaction of the body, remdesivir would not work, dexamethasone would work. And finally, if the patient is already vented or an ECMO, you probably best bet would be the dexamethasone. Now, I talked about the things that work. Let's talk about the things that don't work. So for example, Kaletra or lopinavir, ritonavir, that was tried and alone without any other combination does not work. So please don't use it. Zithromax was tried alone and with hydroxychloroquine does not work. Please don't give it. Antibiotics also, they don't work for viral pneumonia. The risk for co-infection with bacterial pneumonia is really small, it's about 7%. So, kind of routine antibiotic coverage for COVID-19 is not indicated, and it can be harmful because actually there are more reports now we see about the effect on the microbiome, on the gut bacteria, and the gut bacteria killing this gut bacteria actually can lower your immune reaction to COVID-19 and may affect the severity of COVID-19 infection. So please don't give antibiotics. I don't think there's any medicine in the modern history that got as much political kind of charge as much as hydroxychloroquine, which we have multiple randomized control study that showed it's ineffective. It does not work in COVID-19, whether alone or with Zithromax. And finally, supplements, except for vitamin D, which may or may not work. I don't really see a value of giving zinc or vitamin C or other supplements. And finally, this is where we stand with the vaccine. We have 3 vaccines, 2 vaccines already approved in the United States, Johnson & Johnson coming hopefully next month or the month after, and AstraZeneca probably going to be approved sometime in March. And thank you so much.
Thank you so much for a terrific overview of COVID-19. A very powerful talk. Our next speaker is Dr. Rob Colon. Rob is an associate professor of medicine at Wright State in the Department of Internal Medicine and is the associate chief medical officer at Miami Valley Hospital and chief of quality for Premier Health. Rob.
Thank you, Dr. Solomon. I am going to go ahead and begin projecting if this will allow me. So I am going to see if that is projecting yet. All right, and if I can get a quick thumbs up from somebody on screen.
Yes.
Good. All right, perfect. So thank you, Dr. Solomon, for that introduction. As I said, I'm Roberto Colon, the Chief Medical Officer at Miami Valley Hospital. And what I'm going to try to do today is run through a quick update on COVID-19 and try to focus a little more on our more local area, taking a look at Ohio and specifically here in Montgomery County. One of the things that I've been doing throughout the pandemic is creating just a bit of a timeline for where we have been. And I have been updating this timeline since about the beginning of the summer. And as more events come up, I take some away and add more. And it got so complex that I really had to stop when we got to this star, which is when we began vaccinating. But if we go to the beginning, you realize that the first report that came out regarding COVID-19 as this emerging disease was December 31st of 2019. And it was exactly a year to the date tomorrow where the first case was reported in the US. Since that time, we've learned that perhaps there were more cases actually around at earlier times that were not recognized, either because we didn't have the symptomatology right or because we did not have the necessary tools for testing. But this is the timeline that was created from the information that was there. And as you see moving through, one of the things that is very telling is the times that we go from 1 million to 10 million seemed incredibly long. But as we progress, it takes us less than a month to increase the number of cases by the tens of millions. As you can see, December 19th is when I stopped updating this timeline when we hit 70 million cases worldwide. That was a month from today. Where we sit today, we're 95 million cases worldwide. That means in a month, we added 25 million cases. This is something that is incredibly fast, and it keeps gathering more and more speed as the prevalence of disease has been out there. And the last month has just really exploded with the number of cases. Worldwide, we've hit over 2 million deaths, unfortunately. At the US, we've had, this is as of this morning, 24 million cases with currently 123,000, almost 124,000 Americans currently in hospitals. And probably being eclipsed today is 400,000 individuals who have died in the United States. This is in a year's time. In Ohio, we've now had more than 830,000 cases and currently 3,800 individuals who are hospitalized, with more than 10,000 people who have died. That's just a daunting number for a disease that we just started talking about a bit over a year ago. When we look at the trends in Ohio, this is going back to when we began tracking around the beginning of April. And there are different pieces of data in here that I want to highlight. As we look at the number of cases, we can identify three very distinct peaks of activity. The very early peak that occurred during last spring, when we really were preparing for the worst of the worst. This late summer peak that we started seeing around July through August, and then the final peak that we have just crested over that occurred as an exaggerated and prolonged upward swing that took us through really most of November and December before finally starting to decline around Christmas time with a last peak at the beginning of this year. This mirrored very much what we saw in the rate of hospitalizations and deaths. What you will notice between the rates of hospitalizations and deaths related to COVID cases, if we were to dive down a little more specific, there is about a 1 to 2 week delay, because we know that most people that are going to be hospitalized are going to have that hospitalization occur after they've been sick for several days. Usually after 5 to 7 days is when we start seeing the worsening of the symptoms, and the fatalities will typically occur a bit later associated with COVID-19. So there's a bit of that shifting in the timelines. Those three peaks are evident in almost every piece of data, whether we're looking at the number of patients that are currently hospitalized across Ohio. You see that those peaks really went up around similar times. The daily counts of positive patients within those hospitals. And this is evident in any kind of setting, whether we're in a rural environment or a more urban environment. When we look back a little more locally, we know that around March 9th is when the first case of COVID-19 was identified in Ohio. We know that in March 18th is when we first reported locally that the first case of COVID was being worked up and about to be confirmed. What's happened since that time is sometime in May, they looked at the antibody test for 2 individuals who had had respiratory illnesses as far back as January, and they were able to detect the presence of COVID-19 antibodies, SARS-CoV-2 antibodies, identifying that the disease was probably within our state much earlier than we had anticipated, but that was the first data that we had. As we move forward through the timeline, around November 25th is when things really started to get bad around here, and it's when we moved into that purple or level 4 emergency for COVID-19. And all of you have seen those maps that the governor updates very frequently, and we have been tracking that change in the color until every county really in Ohio was in the red, and we eventually moved into that purple activity. Locally, we saw the peak of the activity the week of December 13th before we started seeing that downward trend. This is what's happened in our county as of yesterday. We have had a total of 41,000 cases. Again, you see the distinct 3 humps of cases in here, although what you see here towards the late part of September was a blip related to some of the testing catch-up. When we looked at the hospitalizations, we see again this early blip, the second one during the summer, and then the prolonged. This is a dual phase, as we talked about, because we went up, we came down in the number of cases towards the end of December before going back again into January. So this is what the local activity has looked like. And this is from data that comes right out of the CDC, again, going back to April and looking at what's happened the last 7 days. So we've started finally seeing some steady improvement in almost every one of our metrics. The number of cases has actually declined by about 27% in the last week. There's a decrease in the positivity rate, which is one of the most important markers that we look at to see what is the prevalence of disease. There's a decrease in the number of new admissions and the percentage of beds being utilized for all patients as well as ICU. So we're finally really starting to see that shift in the curve. When we look a little more specifically at what was our experience here at Miami Valley, we looked at, this is a graph that I put together from April all the way until yesterday. And there are three pieces of data. The dark, smaller columns highlight the number of patients that are currently in the hospital with COVID or COVID-related illnesses. The orange bars in the back is the total census of admitted hospitalized patients. And this green line is the percentage of all of our patients in the hospital who actually have COVID. And as you can see here on the right is a percentage. Towards the beginning of the year, we had a much lower census because, as you recall, a lot of the elective cases were being cut down at the point to make sure that we conserve PPE. As we progress through the year, the number of patients in our hospital has grown, and we've seen, again, the three peaks of the number of cases becoming very evident. And what's been really staggering is in the last month, for a big portion of the time, more than a quarter of the patients who were in the hospital were here for COVID disease. And we hit a peak of approximately 32% right after the beginning of the year. This is finally starting to see this steady decrease once again with this gradual decline in the number of patients. So we've seen really that ebb and flow of the disease that continues to unfortunately be a problem. What we've learned, as was just covered, is not a lot of great treatment. So the focus of everything we do is prevention. And we've beaten this to death, and everybody knows what we got to be doing. But we finally have been able to get this new tool for active prevention utilizing our vaccine strategies. And currently we have two vaccines, Moderna and then the Pfizer BioNTech vaccines that I know Dr. Burdett's going to cover in more detail. But talking about how this was distributed, we first got the Pfizer vaccine in our area in December 14th, and that was really earmarked for the congregate housings and was distributed without most hospitals really being directly involved. Initially, there were approximately 123,000 doses that were earmarked for those residents and staff in those facilities. And then Moderna arrived approximately a week later, and this was earmarked for the rest of 1A, looking at the healthcare workers. Approximately 200,000 doses were received in that initial batch distributed throughout Ohio. Every week there has been an additional allotment with the goal of trying to get as many people vaccinated within the healthcare group as possible. I will tell you that one of the most frustrating things have been the low numbers of vaccination rates that we have had among healthcare workers, despite all the education that we've put out there. And it's not a unique thing to our area. We are seeing this across the entire country, where in some areas the rates are as low as 30% of the healthcare workers who are willing to be accepting that vaccine. And we just have to do better than that if we're going to be protecting ourselves. As you've probably heard a lot, today we began vaccinating Group 1B, and I was actually fortunate enough to be there this morning and see the first group of our octogenarians, and this is not one of them, this is one of our healthcare workers, one of the physicians here was actually able to receive the vaccine last month during part of that 1A rollout. But it was great being able to see the group of octogenarians who are really at the highest risk for bad outcomes from the disease finally be able to get this vaccine. So really running through what the governor already talked about a bit earlier, our 1A plan began December 14th. And it was focused on healthcare workers and making sure that we are protecting those who are going to be responsible for keeping our facilities open. We've now began phase 1B, and this is a phased approach that began today, looking at anyone over the age of 80. Next week, the plan is to expand it to anyone over the age of 75, as well as those who have severe developmental disorders. And those are going to be including a lot of hemoglobinopathies, inborn errors of metabolism, and other diseases that appear to be associated with higher rates of mortality as well. Moving on to February 1st, that expands again to anyone over the age of 70, as well as employees of the K through 12 schooling systems when they do have a plan to go back to school to make sure, as the governor said, to get back into academics. And then February 8th, expanding it to everyone over 65, which will actually be a huge chunk of the population. The subsequent plans, whether we go to a 1C or 2, et cetera, are still being finalized from the state, but it's very unlikely that we're going to be having a widespread open vaccinations to the general public until late spring at the earliest. And certainly need to make sure that you understand currently the vaccine is not available for everyone. The youngest that we currently have who are able to be vaccinated is anyone over the age of 16, and that's with Pfizer because Moderna requires 18 and up. There are going to be more and more pieces of information coming out. I'm sure Dr. Burdett's going to cover this as well, but important to highlight over and over, there are very few absolute contraindications to the vaccine, and they mostly focus around things like severe allergic reactions to vaccine components. One of the pieces that I'm sure he's going to emphasize as well is how we have got, to emphasize how safe this vaccine is for women to continue to drive up the rates of administration. If you look around the state, we have expanded the locations to be able to receive the vaccine, and presently 700 different locations offer this. It includes hospital, pharmacies, and public health offices that were part of 1A, but now also additional health centers, some offices, as well as more pharmacies. There are thousands of facilities across the state that have applied to be vaccine, that apply to be facilities that can administer the vaccines. They are going to gradually be rolled in order to make it easier for us to be able to administer the vaccine. We know it's becoming a success because all 1,100 spots that we had open at Premier are already full for the past week, and they were full before the clinics opened today. So there is a need for more vaccination and additional allocations that will likely be coming out. If anyone has any questions about where you can get vaccinated to pass along to your patients, these are two great resources from the Montgomery County Public Health Department, as well as from the Ohio Department of Health, to be able to find out where you can get the vaccine. In order for us to succeed, we have to realize we're not done yet. The vaccine's here, but we still have got to make sure that we're sticking to those recommendations, limit the gatherings, and mask, even after you receive the vaccine. That's also why that communication and education is going to remain so important, and why programs like this are going to be key to successfully navigating this pandemic. Got to make sure that we're doing so by reinforcing the science of the vaccines and continue to strive to move forward to immunize more and more people. Thank you very much for your attention.
Thanks, Rob. Appreciate it. My apologies for not calling you the Chief Medical Officer. You were promoted. I'm sorry.
That is
not sorry you were promoted. I'm sorry that I didn't mention it.
That is quite all right. Hot off the press.
Our next speaker will give our pharmacy updates, and that's Cynthia Shepard Solomon, a pharmacist and a clinical associate professor of medicine in our Department of Internal Medicine.
Thank you. Okay, here we go. What I want to talk about first, if I can, is a little bit about the fact that none of the vaccines that you've already heard about today have yet received full FDA drug approval. There are two vaccines, however, that you've already heard about, both requiring 2 doses, that have received the emergency use authorization. And that is after they have submitted 2 months of data post-second injection. And what's important here is that we understand that the EUA allows us access to vaccines that have not yet been approved fully by the FDA. Both of those manufacturers you've already heard about, Moderna and the Pfizer-BioNTech. And in order for a vaccine to receive the actual full FDA approval, manufacturers must submit at least 6 months of clinical trial data and perhaps as much as 10 months of data on a pre-established number of patients. So as they are in the EUA category for emergency use, they continue to provide data on those phase 3 studies. You can see here there are several others that we are hoping within a month or two to see available under this same category of use. The Johnson & Johnson, the AstraZeneca, and Oxford University, and there are dozens and dozens of other vaccines in the pipeline. So let's talk a little bit more about the emergency use authorization. It comes from the FDA, and it really facilitates the use of these medical therapies, or vaccines in this case, during a public health crisis. It allows unapproved medical products that have shown to have interim, preliminary kind of safety and efficacy that they can be used, and it allows unapproved uses for approved medical products in some cases. But in this case with the vaccines, what we're looking at is trying to allow patients access when there is no other adequate, approved, or available alternative right now. And as I mentioned, we are continuing to collect the data. It will allow us and require that those trials continue to the full fruition of the FDA required drug trials. So in order to do the EUA, what has to happen is that we have to have a really good system of safety monitoring in place. And we do have many different systems available for observing, for surveilling, and then evaluating various adverse drug effects. Particularly important right now as we begin to vaccinate is picking up those kinds of effects that have not necessarily been seen in the clinical trials heretofore. And I want to mention just 2 of the systems that are in place that you will become very familiar with. The first is the VAERS system, and it is a vaccine adverse event reporting system. And it is a system that the FDA requires the healthcare professionals to report specific certain adverse drug events that occur post-vaccination. You can find that list on the EUA fact sheet for healthcare providers. We have lots of references for you, and you will be able to see those during our conference. So we have access for you. The VAERS reports are filed without regard to causation. So it doesn't matter if you think it's vaccine related or not. If it is an adverse drug effect that you are finding in your patient, you want to report it, and you have a responsibility as a healthcare professional to report that. Vaccine recipients may also file the reports. Here is the access for the link, and you will read more about that on both Pfizer's and Moderna's fact sheets. The other program that is very important for us to be aware of is the V-Safe program, which is an elective patient tool that is a compilation of collaboration between the CDC and the FDA. And it is smartphone based, it is elective, but it allows for patients to have a health check the first week daily, and then each week after there is a check-in, and it requires some basic information and web surveys to be filled out. It's actually quite a remarkable and easy way to let people know that you are having a problem, if you indeed do have a problem. So if a side effect is reported and it is significant enough, A telephone follow-up does occur when it is a concern. And then this particular system also allows us to help patients know that their second dose is due. I'll just mention, because we are a community of the VA and the military as well, both have their own versions of these two systems, the VAERS and the vSafe. And with the military, of course, there's a hook in with the Department of Defense. But there's a mechanism nonetheless for all of us to, as healthcare professionals, report the ADEs, and as patients to check in post-vaccination. I want to just mention a little bit more about the contraindications to both of these vaccines that are messenger RNA vaccines. If your patient has a history of an immediate allergic reaction of any severity to any of the ingredients or components of the vaccines or to the chemical polysorbate, then they should not receive the vaccine. Now, the reason polysorbate is in there is that it happens not to be in the vaccine, but it is related to another chemical that is in the vaccine, and that is polyethylene glycol. So any of these kinds of situations, if you have a history of a patient who has a problem, they absolutely should be exempted from the vaccine. Another case that is important and very relevant is people developing severe allergic reactions in the case of their first dose of vaccination. And if there is an anaphylactic situation or other severe problems after the first dose, then that patient should not receive the second dose. And the vaccine ingredients can be found both on the manufacturer's fact sheets as well as the CDC website, Appendix B, under interim clinical considerations. But it'd be very important to make sure that you have access to that as you chat with your patients. I want to talk a little bit now about how important it is to document properly. And of course, there are state and federal rules about how one is documenting the individual vaccination as a healthcare professional. But I know as a pharmacist, I have responsibilities to document in a certain manner all the information that is relevant about each vaccination. And here is a link to more information about that through the pharmacy board here in Ohio. What is also important is that the vaccine recipient receives a card or a printout in some cases with specific information about their vaccination. So for example, if it's the Moderna manufacturer, we want to know that. We want to know the lot number. We want to know the date for revaccination. And then you certainly can put information about how to access the healthcare professionals if there is an emergency problem. But this will be very important to each individual patient and will hopefully help to stop any kind of problem when they go for their second dose about which manufacturer they had the first time. So with second doses of the vaccines, as you've heard, we do a 2-dose regimen. The Pfizer has a 21-day interval in between the first and second, and the Moderna has a 28-day interval. Most vaccines in general have a regulation from the FDA saying that there is a 4-day grace period. And in this case, several organizations have already made some statements that we need to really take seriously about the fact that that 21-day or that 28-day interval stay 21 and 28 days. So if you have to schedule a patient differently than the 21 or the 28, you want to go for the longer interval. So instead of 28, you might have to go to 29 or 20 or 30 days, but you don't really want to, if you can help it, go into an earlier time period. So longer interval versus shorter interval. What is very important to remember, though, is that once you've passed that 4-day grace period and you go into the 5th day, it actually invalidates the dose. So we want to stay within the 4-day period right now. I know there's been a lot of hype about can we do things a little differently, but right now, as the regulations are written, we have the 4-day grace period. I want to just hit a little bit on the rollout. We heard from the governor about the rollout. We've heard from Dr. Colon about the rollout. All of the moving pieces have not been totally smooth, and you would expect that everything wouldn't go exactly as we had anticipated. There are a couple of places that I think we need to talk about. One is with vaccines, they are biologic entities, and as biologics, they do not go directly from manufacturer to the marketing. Instead, there is a period of time where there are quality control parameters that are involved in each of those lots or those batches. And it could take days or weeks, perhaps, for each lot after manufacturing to actually be approved and then move to transportation, move through the logistics of getting to the site where they will be utilized. So it's important for us to calculate in a little bit of a variable there. We haven't really heard that. And General Perna, who of course headed up the important work nationally, has said that he has made some mistakes regarding this kind of issue. And we need to just realize that this is not going to be something that is black and white. It's going to be a variable throughout, that there may be issues about a batch that doesn't make it through in as rapid a time period. So just this week, post-marketing, California has pulled a Moderna lot that was linked to a greater percentage of allergic reactions. So 333,000 doses have had to be pulled. And this may happen again. What happened here was that the number of allergic reactions that were occurring was higher than the average, and they began to get much more concerned about that particular batch. So they pulled it. Another challenge, just briefly, that you need to be aware of is with the long-term care facilities, and it has to do with informed consent particularly. Some patients are not able to sign their own forms, and because of that, healthcare powers of attorney have needed to be contacted, and that has taken a longer period and may be a continuing issue for some of the patients who just cannot speak for themselves. I want to just talk a minute about partnering with your local pharmacist. The pharmacist down at the corner or perhaps in your town, they are people who can help and can answer questions if you are having difficulty. They can administer the vaccines, and with the assistance of their interns can also administer vaccines. And in Ohio, some specially trained qualified pharmacy technicians are also able to administer. You want to think about designating 1 or 2 of your staff if you are going to be doing a large quantity to draw up the doses. That way, the doses can be cross-checked and it reduces the opportunity for error. And to use all the vaccine every day. So if you're thawing a certain amount, don't waste that amount. If it ends up that you are no longer having access to the 1B population that day, that doesn't mean you can't vaccinate someone else who is present, who could be a recipient. So we don't want to waste any vaccine. Some of the errors that have been reported are injecting vaccine with no diluent. The Pfizer has a dilution that is required. And of course, the Moderna has no dilution. So you can see that there are some variables here that can cause some confusion. Injecting too high or too low a dose has occurred, and injecting with incorrect syringes. So those issues are all specified on the fact sheets for healthcare providers as far as syringe size goes. Here is what we've already talked a little bit more about, the issues of who is in each of these priority groups. We are in the 1B group. I'm not going to talk more about it, but here is a list of the pre-existing conditions that Dr. Colon referred to, and very important to get these folks vaccinated as soon as we possibly can. Now, the next couple of slides, this is Montgomery County for your access right now. Here are phone numbers and links that can be utilized today for people who might need to get an appointment or get pre-registered. Many sites do not even require an appointment. So very important, here is Greene County, important for your patients to know where they can go and get access. I've got some references, and additional references that I have utilized are in the toolkit you'll hear more about later in the conference. Thank you for your time.
Thank you very much. Our next presentation will be our COVID-19 vaccine update. Dr. Steve Burdette, who is our Chief of Infectious Disease here at Wright State University and a professor of medicine in our department. Steve, thank you for joining us.
Thank you for having me. 1 second here. All righty. Good afternoon. If I misspeak at all, we can just tell it's probably because Dr. Fauci told me to say what I said. So he's here backing me up just in case I run into any troubles. As you can see there, I don't know that any of our speakers have actually come out and announced it, but I did get my first vaccine on December 29th. I am due for my second vaccine on the 26th. And my only other disclosure that I have to share is that I think COVID sucks. I'm still curious. I'm hoping to get that on my license plate. I'm just not sure if the DMV is going to allow the word sucks on a license plate, but I am going to try. So over the next 20 minutes or so, a little more clinical information, because that is my kind of my niche. I'm going to skip over some of the stuff in my slides because I think I've got a little bit of duplication on material, and I'll point those things out as I get to them. As you can see here, we've been talking about, the trials and the vaccines and whatnot. This is just a vaccinology, or honestly, drug development 101. You've got the discovery phase, the preclinical stages, and then you get into phase 1, phase 2, and then phase 3. A lot of the stuff that I'm going to get into, I've kind of focused a little bit on Moderna. A lot of the data is very similar with the Pfizer vaccine. Our healthcare workers here in Dayton got Moderna, and so I just, for the sake of time and the sake of duplication, a lot of my emphasis was more on that side. But again, you can cross-relate a lot of it. We'll talk a little bit more later on about things that are coming down the pipeline. But, obviously the messenger RNA, everybody's probably said mRNA now more times than they have, other than when they were a first-year medical student, since the vaccines have been discussed. There's a lot of other things coming down the pipeline. And some of the safety information that I'm going to share today and some of the clinical decision-making is very specific to messenger RNA vaccines. You've got some live virus, you have some attenuated viruses, you have some protein vaccines that are coming out. And there are so many different mechanisms with these vaccines that there's not going to be a lot of the information for one may not apply for the information for the others. So please take each one of these vaccines as they come out. The Johnson & Johnson vaccine, which has been mentioned a couple of times, that will be our first ever human adenovirus vaccine. And that's an adenovirus that does not replicate within the humans, but there is still some question on its role in the immunosuppressed host. But that will be just like messenger RNA has kind of been a big hot topic. Once J&J's comes out, it'll be a lot of discussion on adenovirus vectors and adenovirus vaccines. So more information to come, but please, as I go over some of the safety information and some of the comments, these are very specific to messenger RNA vaccines and cannot be applied to other technologies. So again, we've got nucleic acid vaccines that are coming. Again, Moderna and Pfizer, obviously names we all know now, are, this is our messenger RNA process. Viral vectors, again, I mentioned Johnson & Johnson. A lot of these are adenoviruses. There are some other viral vectors that, again, are not meant to replicate within the human body. The reason that most of the viral vectors, or a lot of them, especially the adenoviruses, are single vaccines, so single dose vaccines, is because you develop immunity to the adenovirus itself. And so you cannot give repeated doses of those vaccines because you're going to have an increased likelihood of having a reaction to that. There are the inactivated vaccines. A lot of that is coming out of China. We've used those for a lot of other diseases. Those typically need boosters. And then again, protein vaccines, Sanofi and Novavax are working on those. To me, as we look at the success and predicted success of the vaccines, it all comes down, in my opinion, to broad spectrum immunologic response. So those vaccines that get you CD4 and CD8 responses, to me, are going to have a much better chance of having good efficacy than something that is just antibody immunologic response. When you look at the old shingles vaccines, the first one was just an antibody response. It didn't really create much T cell immunity, and it was okay, but it wasn't great. Then the newer Zoster vaccine comes out, develops, you do elicit a T cell response, and the vaccine efficacy goes up greatly. So as we get into some of the final slides, as I show you, again, some more information on some vaccines that are coming, to me, what I want to know, at least to the level of which I understand vaccines, I want to know, does it stimulate both an antibody and a T cell response? So again, this just breaks it down once again, and you can see there in the circles the number of vaccines that are kind of in process for this. So preclinical, there's hundreds of them. Lots of emphasis on protein subunit, which are kind of a classic vaccine, tend to be relatively safe, though may not be as effective. Working on live attenuated, again, those are highly concerning for your immunosuppressed host. And then you have your RNA and your DNA vaccines. Most of those, again, are in preclinical, and then you get into phase 1, phase 2, and then by the time you get over there to the right to phase 3, it's only a handful. Novavax, there is the Beijing Institute, J&J has one, and then again, we've already got the Pfizer and the Moderna that are available under EUA. And then again, none of these are licensed yet for full approval. So one of the big misconceptions, and I know Dr. Hawley is going to discuss a lot of this stuff in the next lecture, but a lot of those thoughts about messenger RNA is we fast track this. We did not put the time and energy into it. These aren't ready for prime time. Well, messenger RNA vaccines have been around for a long time. Actually, quite interestingly, a lot of the HIV vaccines that have been studied were actually based on messenger RNA. They've done Zika, they've looked at CMV, they've done rabies viruses through rabies infections through this. They've done West Nile studies. So the messenger RNA platform for COVID vaccination has been going on for decades, okay? But when COVID became what it was in the late 2019, they were already, at least Moderna was planning on rolling out an influenza phase 3 study using messenger RNA technology for influenza vaccines during 2020. But when COVID became an issue, they just took their technology, isolated the messenger RNA from the COVID vaccine, from the COVID virus, and then turned that into what we now have as our COVID vaccine. So don't let people, one of the misconceptions is, again, we created messenger RNA and we did all this in the last year. That is not true. Messenger RNA has been used in clinical, preclinical, basic science studies for decades and is actually used in many non-infectious diseases. They're doing a lot of it. A lot of the antibody therapy with cancer treatments are being done with messenger RNA. Here is the Moderna. And again, I'm pretty sure that the Pfizer timeline would look very similar. Again, the outbreak was identified at the end of December 2019. They sequenced, within 2 weeks, they had sequenced the messenger RNA to start preparing it for the vaccine. They were able to ramp up its production very quickly. They got it into the preclinical studies within 6 weeks of the outbreak starting. By February 19th, so again, barely 2 months in, they had confirmed immunogenicity within the mice. And they realized that, again, it was the spike protein that patients were responding to. And then by the end of February, they had product available. And then they got the FDA go ahead. So within 3 months' time, they were able to start moving forward. Quite impressive. And again, if this had not been technology that had been used for decades, this technology would be just like all the other vaccines in preclinical studies trying to see if they're effective. So again, big misconception. Messenger RNA vaccines have been in the works for a long time. One of the issues with vaccines that you see is the adjuvant. The adjuvants are many times what cause side effects from the vaccine. Again, it's the adjuvant that makes the vaccine more potent and the immunologic response more potent. With messenger RNA vaccines, there is no adjuvant needed. So again, these are pretty clean vaccines. I've run employee health clinics for many years back in the past, and we had a lot of issues with influenza vaccines and side effects. And what we found is the vaccines without adjuvants, without preservatives, tended to have less reactions, less side effects. And so again, no adjuvant with either the Pfizer or the Moderna vaccine. And again, to me, the process that makes these vaccines more effective. And throughout the era of COVID, I have been wrong on a lot of things, and I'll be the first to admit it. And I honestly did not think that our first vaccines would be all that effective. I thought the first vaccines to hit the market were going to be moderate to okay at best. But it turns out, I think I might be wrong on that one. I think the messenger RNA vaccines are going to end up being very effective. I'll also be the first to admit that I always take clinical data from a pharmaceutical study with a bit of grain of salt. And I really want to see how the clinical experience with this medicine, with this vaccine, how it does in the real world. Okay. Your patients for a clinical study are somewhat cherry-picked to try to have good vaccine responses. Obviously, as I'll show you, the response was 95%, 90%, whether it was Pfizer or Moderna. Again, that is phenomenal for vaccines, okay? But I am still holding out a little bit to see what happens as we get more and more people vaccinated. How does it work in the real world? There in the bottom, again, you got your major histone compatibility 1 pathway, which leads to CD8 T cell stimulation. And then you also have your MHC2 pathway, based on the antigen. And again, Dr. Ali's video kind of went through some of this, and I'm not going to spend much more time on that. But it's that MHC2 pathway that leads to B cell, which leads to your antibody response. So again, one of the reasons that the efficacy does not surprise me too much with this vaccine is because we are getting both CD4, CD8, as well as the B cell stimulated with this vaccine. Again, same kind of nomogram. You get the vaccine, again, as Dr. Ali's video mentioned, it's that lipid coat where if people are going to have a reaction to the vaccine, many times that is the cause. It is translated in your dendritic cells. Again, this is not changing your DNA. This is not changing your genetic material. This is our antigen presenting cells doing what they do every single day, okay? They develop the spike protein. The spike protein is then used to stimulate both MHC1 as well as MHC2, which gives you your CD8 response, and your MHC2 gives you your CD4 and B cell response. I will not watch this video. It's about 3 minutes. It's somewhat similar to what Dr. Ali showed. But again, if you want to watch that, that will show you the physiology of how these vaccines stimulate the immunologic response. So what I was asked to mostly do is get into some of the common questions regarding our vaccines. I will encourage everybody to do a Google search for New England Journal of Medicine. COVID vaccine FAQs. Paul Sachs, a well-known infectious disease doctor, has a very nice section there with a countless list of common COVID vaccine questions. I cannot hit all of them today, but you can utilize the New England Journal of Medicine's website, and they have a very nice site for that. So the most common question that I get is, I am allergic to X, Y, or Z. Can I get the vaccine? Okay. So according to the United States Center for Disease Control, patients with a history of severe allergic reactions can get it. They can get the COVID vaccine. We just have to watch them for 30 minutes, okay? Now, this is just for people with allergies in general, okay? If you have family history, or if there's medications that you're allergic to, again, you can be vaccinated. CDC is being very aggressive in vaccinating folks with this vaccine. Now, as you can see there on the third bullet point, the United Kingdom is not. The United Kingdom is not recommending vaccination for folks who have had allergic reactions to other medications. They are being a little bit more conservative, but CDC is being very aggressive. So far, from the data that was published, I believe about 10 days ago from the CDC, about 70% of the allergic reactions that are happening are occurring in the first 15 minutes after the vaccination. And they're all managed while people are still in the clinic. And again, all clinics that are doing vaccinations have to have the ability to handle an allergic reaction. So when people ask me, I'm allergic to A, B, C, X, Y, and Z, should I get the vaccine? My answer is uniformly yes. Now, obviously, if they get the first dose and they have the reaction, it was pointed out to me yesterday, again, somebody had what sounds like angioedema, swelling of their tongue after the first shot. That is not somebody that I would recommend getting the second shot. But we really do want to be aggressive with vaccinating our populations. These are the listed contraindications. Again, if you react to the first dose, do not get the second one. If you've reacted to any of the components, the big one being polyethylene glycol, PEG, then you need to be careful. Now, again, the PEGs come in different numbers, different shapes and sizes. I've been asked this twice already, and my first reply is, I am not a PEG expert. But to me, unless you can find an immunologist that can say that you can get PEG 15 versus PEG 72, if you're allergic to PEG, I would stay away. And then again, if you do have any sort of reaction to the polysorbate component with it, that's part of the PEG. Other than that, again, folks should be vaccinated. And if people do have an allergic history, an allergy history, they should be watched for 30 minutes. Everybody else can be watched for 15. So what components of the vaccine? I put this in for the medical students because I think the only one that cares about 4-hydroxybutyl bis, hexane 6,1-dil bis, 2-hexodecanoate, 2-polyethylene glycol, 2000N. Okay, I'm going to stop because it keeps going. Only as a person that would care about that as a basic scientist or a medical student. Clinically, what I can tell you is there's not much to these vaccines, okay? The Moderna vaccine has a smaller base component. There are no preservatives. There are no adjuvants, okay? Pretty clean products. That's also why these things don't last very long once you have warmed them and taken them out of the freezer. It's also one of the reasons why the Pfizer vaccine has to be kept frozen at such a cold temperature, is because there are no preservatives in here, okay? So minimal components to this vaccine, to me, is another reason why we should be aggressive in vaccinating folks who have a history of allergies. So again, what is there data on whether patients with asthma are more prone to an anaphylactic type reaction? There really isn't, okay? Again, severe reactions to any other vaccine is not a contraindication to vaccination with this. And as I mentioned earlier, 70 to 75% of reactions are occurring while people are still sitting in the clinic. And so to me, that is encouraging. It's not like most reactions are happening 3 and 4 hours later when somebody is at home. Majority of them are happening while they're still sitting there. So again, from an allergy standpoint, outside of somebody who has a reaction to the first vaccine, outside of somebody who's allergic to PEG, there should be very limited reasons not to encourage vaccination. These are the side effects. This is from This is from New England Journal, published in November 2012. I believe this is from, I think this is Moderna. I don't think this is the Pfizer study, but I could be wrong. The one unique side effect that everybody on this call needs to know about is down there toward the bottom, which is the size of erythema or redness or the induration and swelling in the arm. With this vaccine, when those T cells, I've emphasized those CD8 cells, when those things kick in, about 7 to 10 days after the vaccine, a significant, I've seen as high as 40% of people will have redness at the site of injection. They will have lymphadenopathy at the site of, near the site of injection, so usually in the axilla, and it will be quite impressive, okay? Do not send the person to the emergency room. Do not send the person to an urgent care. If they have that, that's what's known as normal. That is not a contraindication to the next shot. That is just evidence, again, that the vaccine is kicking in, stimulating your immune system, and you need to proceed. If you have an anaphylactic reaction, if your tongue swells and you can't breathe or your throat swells shut, that is an anaphylactic reaction. You should not get shot number 2. But swelling at the injection site is actually, to me, yay. It means the vaccine's kicking in and working. Can you get COVID from the vaccine? No, but can you get sick from the vaccine, or can you get sick after you get the vaccine? The vaccine has been shown to prevent severe disease. It is very effective. I'll show you the clinical data here in the next slide. What we don't know yet is, can you get asymptomatic infection after getting the vaccine? Okay. Again, I'll show you the data there. We really just don't have enough clinical data, and that's why we're going to continue to emphasize, as Dr. Colon said, wear your mask, socially distance, even after you've been vaccinated. I was texted earlier today about some doctor had both of his COVID vaccines, and he was wanting to know if he still had to be tested for COVID before his surgery. And the answer at this point is yes, because you can still have potentially have asymptomatic COVID. You could potentially be contagious, and we just don't know it. We just need more clinical information. And so we need to keep our guard up. Again, the distinction between immunity that protects you from developing severe symptomatic disease is different than the immunity that keeps you from getting infected, period. Remember, if you go to somewhere in Africa and you take your malaria prophylaxis, you still get malaria. It's just that you take the medicine and it kills the malaria before it makes you sick, okay? Same component or same idea with this vaccine. You potentially might still develop COVID just asymptomatically, and you might potentially still be able to shed it to somebody else, and we just don't know it, okay? Again, failure to appreciate this distinction can lead to a false sense in vaccines that they are protected from infection and thus cannot transmit to susceptible contacts. Until this is all over, we got to keep socially distancing and wearing our mask. If you looked in the Hall of Fame of epidemiologic data, these two graphs would be there. This is from a American College of Physicians article that came out yesterday. Dr. Fauci, the guy right here, was the senior author on it. The Pfizer vaccine is on the left, Moderna is on the right. What you will see is for the first 10 to approximately 14 days, the cases of COVID in the placebo arm and in the vaccine arm are basically identical. They are going up at the exact same rate. Now, you can't compare the COVID, the Pfizer graph with the Moderna graph. They are different y-axes, they are different x-axes, so it's not comparing apples and oranges, okay? But they are both the same mirroring for 10 to 14 days. And then once you get out past 14 days, the rates of COVID significantly drop in the vaccination arm, continue to go up significantly in the placebo arm, okay? So one of the things I've seen is people develop COVID a week after the vaccine, and the people will say, oh, it's a vaccine failure. Or you'll see in the news media that somebody got vaccinated and they still got COVID. Yeah, it's expected for the first 10 to 14 days. After that, it should calm down. I need to pick up some pace here, so I'm gonna go quick here. Again, from the Moderna study, 185 cases in the placebo arm, 30 of which were classified as severe. In the Moderna case study, 11 cases in the vaccinated arm, none of which were severe, giving you a 94% efficacy. Again, you could still have the virus, you're just not going to get it severe. And I've already gone over that. Will we get it every year? Okay, we don't know yet. The clinical study started in July. EUA was granted in December. We don't have long-term data yet. The data that we have shows immunity lasting up to 120 days. For COVID infection, we have immunity antibodies lasting up to 9 months in data. But for the vaccines, the longest we have right now is 120 days. Over those 120 days, there was a 2-fold decrease in antibodies, okay? With prior flu vaccines, antibodies were gone between 6 months and 1 year. Right now, we know they dropped by 2-folds over the first 120 days, so we need more time. But what we don't know is, again, T cells. Will those T cells or those B cells kick in if you are re-exposed to COVID-19, SARS-CoV-2, and will it protect you? And again, there's a nice discussion in Dr. Fauci's article that was published in Annals yesterday. Last couple slides. Again, this the vaccines that are coming out. I mentioned to you again, Johnson & Johnson, it does have T-cell stimulation, but a lot of the other ones do not. They're only going to stimulate B cells. These are the ones that, again, AstraZeneca is probably after J&J's. AstraZeneca's might be the next one to come out. And then again, Novavax is fairly long as well. And this one here, just the reason I put this slide up here is, again, the AstraZeneca does stimulate T cells. The Moderna has, again, CD4, CD8 response. This one does not have the J&J, but J&J did stimulate T cells. And so again, as I'm predicting the efficacy of some of these future vaccines, the T cell stimulation is the best chance to have a good vaccine. I mentioned to you the NEJM article or page on frequently asked questions. Here it is. And again, they go over a lot of common questions that you can refer to get answers. I could not get into pregnancy issues, but ACOG has a phenomenal page. This page is extremely long, very detailed. And I would just encourage anybody who's answering questions on pregnancy and COVID vaccination should refer people to the ACOG page. Was mentioned earlier, again, the bad lot of Moderna potentially. So I'm going to skip over that. And again, Dr. Solomon sent this to me, so I thought I needed to include it. Hospital is not on lockdown after the first patients with COVID vaccine start eating other people. That is what's formerly known as fake news. Thank you for your time.
Thank you, Steve. Much appreciated. Our next speaker is Dr. Brad Hawley. Dr. Hawley is the founding chief of the Division of Infectious Diseases at Wright State University and past president of the Infectious Diseases Society of Ohio, and is an emeritus professor of medicine in the Department of Internal Medicine. Brad, thank you for joining us today.
I've been asked to address some of the misconceptions and unanswered questions concerning the mRNA coronavirus vaccines. I'm not going to cover any of the adenovirus ones. The anti-vaxxers have already been at work, and they've been actively spreading fake news about these vaccines. They've posted online videos suggesting that some of the television news shows that show prominent individuals receiving the vaccine are fake. One video shows a needle disappearing into a syringe, and in fact, such syringes are available to prevent needle injuries. Another video shows an official from Australia getting shot with a cap syringe, and this video was one that had to be shot because the first video with the actual injection had a problem, but the fake news people picked right up on it. A nurse was reported as dying after a vaccine administration in Alabama. Never happened. The pandemic has been denounced as not being real at all. Bill Gates has been accused of planting microchips in the vaccine. Vaccine testing shortcuts have been alleged with no animal testing. In fact, that is untrue. The research was conducted as usual and animals were used. There has been a suggestion that no fetal tissue or fetal tissue has been used in the vaccine. Again, that's been true. Even the Pope has acquiesced to that. However, some cell lines used to test vaccine efficacy, which we'll get into, are in fact derived from fetal cell lines. A common question is, can the vaccine alter DNA? And I think it's worthwhile to appreciate that neither the coronavirus or the mRNA vaccine that mimics the coronavirus enters the cell nucleus. And so they never come in contact with the cellular DNA. And so therefore, there really is no risk that they're going to alter the DNA. Pregnancy is a risk factor for severe viral infection, including COVID-19, and the vaccine offers a potential benefit. Because the vaccine trials made an effort to exclude pregnant women, there is in fact a paucity of data. However, the risk is thought to be very low to both mother and fetus. And furthermore, there appears to be no harm in administering the vaccine to lactating mothers. As Steve mentioned, there's a lot of discussion about that and this issue, and more complete things can be found online, and physicians are advised to talk individually with their patients about this. Can patients be given to, or can patients with allergies be given the vaccine? Well, as has been pointed out, patients with allergies tend to have more allergies. Fortunately, most of these allergies, Steve mentioned, have no consequence when these vaccines are administered. Allergy to any substance or medication containing polyethylene glycol is a contraindication to vaccination. Polyethylene glycol is used in a wide variety of products, including cosmetics, laxatives like Miralax, medications like Depomedrol, and some intravenous contrast agents. While the agent and the mechanism responsible for reactions has not been completely determined, the polyethylene glycol lipid complex is most likely. This complex can activate complement through the alternative pathway and cause mast cells to release histamines, cytokines, and other substances. This reaction has actually been termed to be a pseudo-allergy because no antibody is involved. And in fact, polyethylene glycol in and of itself generates no immune response. It's only when it's combined with another product like a lipid that it can generate this complement-mediated response. Checking to assure that the vaccinating needle is not in a blood vessel is a wise precaution. With these pseudo-allergy reactions with complement, IM and IV routes have been associated with more severe reactions. History of anaphylaxis or severe allergy to any substance is a reason for caution, and vaccination and should be accomplished in a setting that offers immediate medical attention. Polyethylene glycol is necessary to make the lipid capsule surrounding the mRNAs soluble, since polyethylene glycol has a hydrophilic end. Because of this property, it is widely used in a variety of drug delivery systems. The vaccines produced by both Pfizer and Moderna have only mRNA and the protective ingredients. There is no live virus, and therefore there's no risk of COVID-19 infection. These vaccines will not cause a positive antigen or a positive PCR test for COVID-19. COVID-19 patients are rarely reinfected. Because SARS-CoV-2 alters the immune response, the vaccine may provide better immunity. Trials demonstrated no harm to patients infected with SARS-CoV-2 who received the vaccine. There have been some reports of previously infected patients having increased side effects with the vaccination. More data will be necessary to determine the need for revaccination of both COVID-19 patients and vaccine recipients. SARS-CoV-2 has the largest genome of any RNA virus, consisting of over 30,000 bases. However, only about 4,000 bases are devoted to the spike protein, and only a few hundred of these are coding actually for the receptor binding domain. Smaller genome viruses like polioviruses are able to replicate with few mistakes, averaging no more than 1 mutation per genome per replication. Exceeding this threshold is thought to be deleterious to viral existence. The large genome of SARS would be at risk for exceeding this threshold, so a proofreader is necessary. Mark Dennison, who's at Vanderbilt University, discovered a proofreading enzyme in the SARS coronavirus about 10 years ago. While we have proofreading enzymes for our own large DNA genomes, no such enzymes were known to exist for RNA viruses until Mark's research discovered them. The model shows the RNA polymerase in red and the proofreader in blue. As the RNA polymerase moves along, adding complementary bases to the single strand of viral RNA, the proofreader removes any incorrect base additions, giving the polymerase a second chance to add the correct base. This system makes these coronaviruses relatively slow mutators, but the hundreds of millions of infected individuals results in mutations nevertheless. It will be a race between the vaccinations and the mutations. Mutations can be tested in vitro using cell culture techniques so that infectivity as well as the efficacy of the vaccines and the convalescent antibodies can be evaluated. And this is going to be increasingly important as we move forward with more mutations being detected. I think Dr. Lee already had this slide that the English illustrators have put forward of their latest variant, the B117, which is shown here with its 23 mutations occurring in various portions of the genome. And these occur at random. And the largest portion of this genome is actually the 2 open reading frames that code for various enzymes and have nothing to do with the structural proteins. Unfortunately, genome testing in the United States is only being performed on 0.3% of samples. And so detection of mutants is limited. The genome testing is done by some state labs and by universities and private laboratories, and it really varies dramatically from state to state. The most significant mutation in the B117 variant is at the 501 position within the receptor binding domain, where a single amino acid has been substituted. This substitution allows the spike protein to bind more tightly to the ACE2 receptor. The net result is more virus in the nose and upper respiratory tract that can be discharged to infect more people. There is no evidence that this particular variant causes more severe disease, reinfection, or loss of vaccine efficacy. I'd like to close with a quotation from about 50 years ago by the Nobel laureate, Sir Macfarlane Burnet. He states that immunization is the only way to stop pandemics created by respiratory viruses, and global extermination is required to gain back our normal social life. Thank you very much.
Brad, thank you very much for a great talk. Our next speaker is going to be the Mayor of Dayton, Mayor Nan Whaley. And we thank you very much, Mayor Whaley, for taking the time to join us this afternoon.
Thank you all, and thanks for all the great work that you are doing, particularly during this unprecedented pandemic in the world. I was asked just to kind of give some comments on how the vaccination is going locally. And I think the answer I would say is slower than we would like. I think there's significant challenges that we're having to address because this is a tremendous infrastructure that is being built as we fly, as they like to say, and that infrastructure hasn't really been taken care of over the past 4 decades from a lack of real investment in public health. So I think the community and the state are doing the best they can with the situation, and we have amazing leaders in public health. I think in Montgomery County with Jeff Cooper and our Chief Medical Officer, Mickey Doan, who have been tremendous personally for me to help me lead as successfully as possible through this pandemic, but also thinking around equity and ways that we can make sure that the vaccine is accessible, not just to those that want it really, really, really badly. I mean, there's many of folks like that, but particularly places that are harder to reach, like in our areas of low income or people of color. So I'm grateful for their leadership in that work. So today is the beginning, as you know, is the first day that seniors over a certain age, over 80, can receive the vaccine. I can tell you that the calls last week for those vaccines, people calling in, went in a matter of hours. We're still in a scarcity situation with the vaccine. And talking to the governor this morning, I don't think that will change until the Johnson & Johnson 1 vaccine is out on the streets, to say. So I think we'll be in this scarcity situation until then. So it's probably mid to late February. And, to give you a sense, each week the state gets somewhere around 150,000 vaccines every week. Sometimes it's a little lower, sometimes it's a little more. And putting that over the entire location of the state is difficult. And so mayors have been engaging and trying to make sure that we give feedback of what's going on the ground and being real advocates for our local public health agencies to the governor and his leadership team. One example I'll just say that the county public health has done that's well is, for example, this week, they've received 800 vaccines for the 80 plus population. And they took 200 of those and put them aside to do an outpost in West Dayton, actually in Trotwood at St. Margaret's Church, really engaging with the clergy community for the clergy community to decide which church would be best. And St. Margaret's was chosen because it's right off 35. It's very accessible and has no ADA issues. And so they've been really thoughtful about, being intentional, even with a scarce resource, to make sure that we can really drive into these communities of need. And I think that's really important that we start at the front end doing that. In testing, we saw that was really backwards in a lot of places and was at the back end. So I'm pleased that the local health district is really thinking of equity and acting on equity on the front end. If you look at the number of 65 and older just in Montgomery County, it is nearly 100,000 people. So it is, when you add that to the number of healthcare workers in the county, which is about 50, we're already at 150,000 people then. Some of them may overlap a bit, but there's only about 550,000 people that live in the county. So this 1A and 1B is a significant portion of the population. And then, our job as mayors is to try to get other folks to really speak up on behalf of the vaccine. And certainly healthcare providers, doctors, and nurses are the most trusted voice in this discussion of the vaccine. So really encouraging you all to use your voice as someone to really take away any of the fake, untrue stories like we heard earlier, but really share the truth about the vaccine, and we try to share that on our social media channels as well. You would be interested to know that public officials or elected officials are some of the least trustworthy in this issue. So really trying to get clergy members or healthcare providers to speak up on how important the vaccine is for our community. It is the most important thing we're doing right now. You know, if we think about saving lives in our community and getting the economy started, the vaccine is our path to that way. So on the ground in mayors in cities across the state, this is something that we talk about pretty much constantly. We're thinking of how we can do what I call COVID offense teams. We had COVID defense teams. And now with the vaccination, this is the first time we've been able to go on offense with this deadly disease. And so how can we really engage pharmacies, healthcare providers, healthcare systems, public health, and city and county government officials to make sure we're all rowing in the same direction as quickly as possible. So I know we'll get through it. I think it will be bumpy, you know, and it's our job to be as transparent and as honest as possible and to work really, really diligently to take the politics out of this so we get shots in arms as quickly as possible so we get to the other side of the pandemic. I am really excited to be at the beginning of the end of the pandemic. I know we've all been through quite a bit and just super grateful for our healthcare providers and healthcare workers who have truly been the front lines on this emotionally and both emotionally and mentally, but also physically deadly disease. I don't know if there's anything else you wanted me to address, but thought I would come forward and give you those comments of what's happening on the ground here in Dayton.
Mayor Willie, thank you so much for joining us this afternoon. Greatly appreciated. Thank you for your comments.
Thank you. Have a great one. You guys have a good day.
Thank you. Our next speaker this afternoon is going to be Anam Hussain. Anam is a third-year medical student at Boonshoff School of Medicine, has her MBA from the University of Dayton, and along with her sister Wiam, really have been the leading lights in putting together this task force and putting this program together. And she's going to address a toolkit for clinicians. Anam, thank you for being with us and for all you've done for this program.
Thank you so much, Dr. Solomon, for that kind introduction. We've been given a lot of information, and currently on my family practice rotation, I'm a third year, and a lot of patients are just asking just details about the vaccine. And so the kind of point of having this toolkit is just having a place where us as providers in the healthcare field, we have a baseline to go to. So for this toolkit, I kind of found these three main websites that have a majority of the information that's very high yield and to the point. So we have the cdc.gov, we have medohio.gov, and then we have coronavirus.ohio.gov. Out of all of the websites, we kind of filtered through for looking through information for this pandemic. These three have all of the information, and I decided to include the one about vaccine statistics because, like I said, a lot of patients are kind of wanting to know who else is getting the vaccine. So definitely pushing them to want to get it if they're finding out that if their providers are getting it. So I thought it was important that I include that in the top three. The next reminder for the rest of these, the sources that we have, updates are happening every single day. Given that there's changes, and by the time this is published, there will be more information that's out. So this is a constantly changing battle that we have to make sure that we're updated and kind of up to date on everything that's coming out. A lot of these resources have been highlighted in the other speakers' slides, so I'm not going to really go through them, but all of these slides will be available for everyone, and they will kind of be talked about as the rest of this goes on. But that's all I have, and thank you so much, Dr. Solomon.
Dr. Miller is a resident physician in psychiatry here at Wright State University and is president of the Miami Valley Resident House Council. He's a graduate of the University of New Mexico, and we are thrilled to have him talk about what is really a critical issue, and that is we have vaccines. How do we get the vaccines to our population? How do we get vaccines into people's arms? Jonathan.
Dr. Solomon, thank you so much. Hello again, my name is Dr. Jonathan Meller. I'm a third-year resident physician at Rice State University in the Department of Psychiatry. Today, I want to discuss barriers and misconceptions to COVID-19 vaccination. As we consider barriers and misconceptions to COVID-19 vaccination, it's often helpful to understand where these barriers and misconceptions come from. On the current slide, I included a timeline that highlights known occurrences of inequity in this country. Inequity, as defined as a lack of fairness or justice, has led to barriers in medical care. Exclusion, due to established barriers, has led to misconceptions of the system. Historically, inequity in the US has been institutionalized, meaning government supported, as well as based on gender, racial, sexual orientation, and socioeconomic status. The timeline begins in 1748, where by law and under penalty of death, slaves were prohibited to practice medical care. We continue to 1846, where female slaves, without the consent and without the use of anesthesia, were operated on to develop gynecological and surgical techniques. In 1932, the infamous Tuskegee experiments occurred, where African-American men who were enrolled to study syphilis were denied adequate treatment. In the 1960s, Latino and Native American women were disproportionately targeted to be placed on birth control or to undertake non-reversible infertility treatments without giving their consent. Most recently, in 2015, the residents of Flint, Michigan, a predominantly African-American community, were ensured by state and local government that water that contained high amounts of lead was safe to drink. Ultimately, the result of these events is a lack of trust in government and the medical system. Likewise, the conceptions that were established in the community because of these events are still present today and often limit whole communities' access to care. Concerning COVID-19 vaccination, current misconceptions are based on these past community experiences that were highlighted in the timeline. Most notably, the concerns for poor representation. No one that looked like me developed the vaccines. No one that looked like me were in the vaccine trials. Why should I trust it? Substandard care. Why should I trust you? I don't feel like you're doing a good job managing the medical problems I already have. I can take care of myself. Unethical testing. Are the vaccines really effective? They were created so fast. How do I know they even work? Sterilization. Are the vaccines going to make me sterile or infertile? Are they going to kill my baby? And lastly, induced illness. Are these vaccines going to give me COVID-19? Are they going to make me sick? I'll wait and see after other people get it. Currently, about half of Americans say they will receive a COVID-19 vaccine. However, recent polling demonstrated that only 25% of African Americans and 37% of Latinos are willing to be vaccinated. To reach populations that are statistically below average concerning consent to vaccinate, it's important to offer additional resources and effectively communicate the availability of these resources. The picture located to the right of the screen is one of my favorites. Equity and equality are often confused. To achieve an effective response in our patients and our community, and to create an equal overall medical experience, allocation of resources should go to those with the most need. So how do we overcome barriers, misconceptions with patients? As a medical student, I was introduced to a communication technique called NERSE. It's a technique that I use in every clinical encounter. The technique consists of naming the emotion or feeling. It seems you're unsure of getting the COVID-19 vaccine. Understanding the core message. If I understand you correctly, you're unsure getting the COVID-19 vaccine because you don't feel they are safe. Why do you feel that? Demonstrating respect and providing reassurance at the right time. I think if I had experienced the things you did, I would feel the same way. Many people are feeling unsure of vaccination at this time. Notably, it's important to validate how the patient is feeling, as well as normalize their experience. Providing support. Thank you for your honesty. I imagine feeling the way you do, it'll be difficult to go forward with vaccination. Is it okay if we discuss some resources that are available that may address your concerns with vaccination? And lastly, further exploration. I'm curious, what are the concerns or questions you may have about the COVID-19 vaccines? There are many barriers and misconceptions to COVID-19 vaccination. It's impossible to know all of them. However, by using NERSE, the technique on the previous slide, to demonstrate effective listening and to express empathy, it's possible to develop open communication with patients about their concerns. With establishment of open communication, misconceptions can be reconciled and patients can be directed to the resources that they need. The state of Ohio has created a document to address potential barriers to vaccination. For instance, due to only having to provide name and date of birth, undocumented workers do not have to worry about deportation with vaccination. Many additional solutions have been developed and can be found via the reference included in the slide. As healthcare providers, we can get these resources to those in need. We are able to bridge the communication gap between patients and our medical system. Today, we are in a unique position to acknowledge and overcome barriers of the past and to ensure that our medical system is one of inclusion for everyone. For resources that were discussed in this segment, please see the resource toolkit that was mentioned by the previous speaker. For any further correspondence, please don't hesitate to contact me at the email provided. Thank you so very much for your time today and attention.
Thank you, Jonathan. That was a very important talk for us and very much appreciated. What we're going to do next, I know we are past time for the meeting, but I want to open up the floor to questions for our panel. Our panel includes Dr. Abderrahman, I apologize for my pronunciation, a pediatric cardiologist, Dr. David Donraj, who is the chief of OBGYN, Dr. Gary Leroy, who is an associate dean and past president of the American Academy of Family Medicine, Dr. Al Painter, a psychologist, and Mark Rajlich, a med-peds physician. And so what I'd like to do is open up with some questions. And again, if people want to shoot those questions to me on the chat at Glenn Solomon, I'll be happy to pass those forward. But let me start with a couple of questions that we've already gotten. And I'm going to start with the question on the pediatric side. You have patients who have congenital heart disease, you have patients who have other developmental problems. How are you advising the families with regard to the COVID vaccine?
Is it okay? Can you guys hear me?
Yes.
Okay. The vaccines, unfortunately, are not indicated down to below 16 and 18, technically, with the Pfizer and Moderna vaccines. There are some ongoing studies with both Moderna and Pfizer. It looks like the one will get down to 16 relatively soon, I think the Moderna, and they're doing 12 to 15-year-olds enrolling. They're enrolling kiddos for that right now. But again, I think it's going to be months and months before we're anywhere near where we are with the adults currently. There's a UK study with the AstraZeneca product that's going to start enrolling 5 to 12-year-olds. So this is very similar, same thing they've done with previous vaccines, with influenza, et cetera. They start with adults and they kind of move by age group down until it's indicated into down as low as 6 months in the case of the influenza vaccine. I have not heard if people are doing more of a, getting the EUA or a compassionate care use for children at particular risk. Fortunately, the pediatrics risk is much lower, like we've heard from many people, and getting the COVID-19 infection in the first place, and they tend to do better overall. That said, when a kiddo does get it or ends up with like that MIS-C or that multi-inflammatory syndrome, they can be quite ill. And there are, between 0.5% or so in people with underlying clinical conditions, like you mentioned, do poorly with those. So what do we tell them? I think we try to do the regular decreasing the exposure, things we would do with everybody else who is unvaccinated, and wait until there's more data available on the vaccine for younger age groups.
But I want to turn to Dr. Dhanraj because we are getting questions about pregnancy. What about vaccinations for pregnant women? Does it matter what trimester someone is in? What are we recommending?
Yeah, thanks. Can you hear me, Dr. Sullivan?
Yes, we can.
Okay.
Thank you.
Yeah. So our college has been pretty out front on this and trying to help counsel and give us information. And I think in the toolkit, our site was placed the American College of Obstetrics and Gynecology. And I'll just read the two areas here that were given to us that are pretty clear about what they're recommending. The first is ACOG recommends that the COVID-19 vaccine should not be withheld from pregnant individuals who meet criteria for vaccination based on ACIP recommendation priority groups. And then the second is COVID-19 vaccines should be offered to lactating individuals similar to non-lactating individuals when they meet criteria for receipt of the vaccine based on prioritization groups. So there is really no restriction on trimester, or if they're in the process of trying to conceive. The current recommendations coming from our college and for those our expert panels for us that we should not be withholding this. The mechanism of action, as spoken about by Dr. Holly, there really does not seem to be any risk to the mom or fetus. We do know that there is major risk to pregnant moms for these kind of respiratory illnesses. Influenza, for sure, we've always had a much higher rate of morbidity and mortality. The rates are low, in absolute numbers, but the numbers are disproportionately higher for pregnant women if they were to get these. And certainly that's the same kind of trends we're seeing in the data that we're getting. That were the best report out I've seen more recently came from Morbidity Mortality Report Weekly that shows that those same kind of numbers, these women have very high risk of morbidity, mortality, and ICU admissions. And so, really not a lot of our pregnant women meet criteria for any of the groups currently. It's the ones that are healthcare providers. I have several nurses that I care for, and they are they meet criteria, and they should not have their vaccine withheld if they do choose to have it.
Thank you. I guess we don't have too much of a concern about our over age 80 pregnant patients these days. So
Not yet.
Dr. Abdurrahman, what are you telling the families of your patients?
Yes, so can you hear me now?
Yes, we can. Thank you.
Good, good. Since this started, even before the vaccine became available, we have had patients that we consider very high risk because of complex congenital heart disease, which oftentimes means that they have been chronically sick, undernourished, and many of them have very poor immune systems because of multiple medications and multiple syndromes that they have. You couple that with some of the associated lung disease and some of the fact that some of these patients are also premature, you can see why we consider those patients high risk. Luckily, the vast majority of children born with congenital heart disease, once they've had their surgery, they really are effectively cured, and we don't consider them high risk. But for that high risk population, right from the get-go, we have harped on the importance of following CDC guidelines. So for example, when we talk to the families about social distancing, we go into details even before all the holidays about keeping away from families And many of these kids, we actually insisted that if they were going to visit families where it could not be avoided, that those patients be kept in separate rooms. There should be no hugging and no kissing. And we went as far as suggesting that those kids have N95 masks way before they were even suggested for the medical professionals. With what's going on now, we then talk to the families about, hey, vaccines are available. As soon as you have access to it, please get it, so that as many of the family members around that child as possible would have been vaccinated, so they can create a mini environment of herd immunity, at least within their control, even until the greater populace gets vaccinated. We then talk to them about if the child does get sick, what to expect, how quickly to seek care, and then spend a lot of time reassuring them that the vast majority of children really do not have severe illness. Of course, then we have to stress again that even if everybody in the members of the family come down with COVID and the child does not get it, that we're going to continue to assume that child is at high risk, and we will follow that child a lot more closely than we otherwise would, not just with PCR testing, but if they even sneeze, we start tracking antibodies. So it's a little bit different. Maybe we're a little more militant about preventive measures, but that's all we have that we can offer at this point.
Thank you so much. Dr. Leroy, how is your practice impacted by the vaccine? Are you getting questions from your patients, and what kind of things are they asking about?
First of all, before I answer that, I just want to thank everyone for putting this conference together. It's a much needed community-wide event to hear from the governor and the mayor and the healthcare professionals in the know within the community. This is a all-in effort, and everybody is involved, whether they want to be or not. They are touched by this pandemic, whether they want to acknowledge it or not. They are touched, or they have been touched by this pandemic. There's no place to hide. And so consequently, when I start each of my appointments at East Dayton Health Center, where I do my clinical care, now I set aside probably about 3 to 5 minutes to have a conversation with my patients about their concern. Oftentimes I will start by asking, as I'm washing my hands, I will ask them, well, how have you been doing? How has your family been getting along through this pandemic? What are your thoughts? What are your needs? Because no matter what they come in for, we have that COVID conversation, and they need that. Some of my conversations are virtual, so we're using telemedicine, especially for some of my more elderly patients that for a variety of reasons they can't come in, or they don't want to come in because they're afraid that they may encounter someone that will give them COVID, and they know that it's deadly. And many of my elderly patients will say, that come in will say, well, I haven't been out of the house since this started. And this is like my first time going out of the house since this started. That was more during the summer and fall months. So basically, it's an opportunity to educate them about what we know at this point in time, whether it's how to protect themselves, how to protect their family, as some of the other speakers that just spoken about with the children in the house. Well, just because the children don't get the vaccine doesn't mean that we can't protect the house. It's kind of like getting a new baby in the household. You know, now you childproof your house. Everybody over age 2 wears their mask. Everybody washes their hands for 20 seconds or more. Everybody does social distancing when they're going out into the community. So they're learning that. Those that are able to be vaccinated, get vaccinated so that they're less likely to, have this COVID in the household and such. And so it's a learning, it's an educational process. So we talk about the vaccine. But yesterday I was talking to about half of my patients that wanted the vaccine. Another half of them told me why they're not going to get the vaccine. And so we just had a kind of heart-to-heart adult conversation about that, or how to get tested, or where to get tested. What are the resources in the county? So again, us who are at the front line of healthcare need to have that information so that we can give our patients that we interface with that trust us to give them valid information, not just fake news, as it were, because many, if not all, of the physicians that are on this line, and the nurses, they have heard their patients say, "I'm not going to do anything until my doctor tells me to do that." And so that is what they come in and ask, and that is what we do. So it behooves us to, first of all, do no harm. We are living through a once in multiple generations a pandemic, and it's all in. And we have to do things like this so that we're all on the same page, so that we can give credible information to our community members and our patients.
Thank you, Dr. Leroy. Dr. Painter, question for you. Dr. Leroy just told us how important it is to have these heart-to-heart conversations. As a psychologist, can you give us a few pointers for how we might go about having those conversations?
I'll be glad to, Glenn. And first, let me say this has been a great event, and I cannot thank the residents and Dr. Hussein, the medical student, and the Department of Medicine for putting this on. It's incredibly helpful. Some tips, and I think Dr. Leroy has really kind of hit on the two things I wanted to say, and I'm going to be uncharacteristically brief. It's number one, use your relationship, okay? I don't care if you've had a relationship with them for a decade or it's the first time you've ever met them. You still have a relationship with them in that room, in that moment, about something that's very, very important. So use your relationship and make that count. The second thing, and let me come back and compliment Dr. Miller, who's also the president of the Graduate Medical Education resident group as well, in addition to Miami Valley Hospital. I think that NURSE acronym is excellent. I think acronyms, when they're that good and they're that brief and they're that to the point, can really help you focus and stay focused in the moment with the patient. And as a matter of fact, I'm going to make sure that we send that out to all of our program directors, if not by the end of the day tomorrow, so that they can disseminate it to all of our residents. The second thing, and no one's mentioned it yet, but I'm a clinical psychologist and I am acutely aware of it. In every interaction I have with someone, is watch your body language, okay? We've heard a lot about what you're going to say and educating patients, and those are very, very important. Also watch your body language, your eye contact, how you're holding your arms, your voice, everything that somehow or another that doesn't pertain to information. It's that nonverbal information also that really does have an effect on your patient. So those are the two things I would get back to is, one, use that, use that interpersonal relationship with them. And number two, watch your body language. Those things are kind of an X and Y axis of how you can be more effective. So that's what I have to say to you.
Thank you, Al. Steve Burdett, if you are still on the line, I have two questions for you. The first is how long the synthesis of spike protein induced by mRNA vaccines last.
So that's yeah, so that's the one that we know we're at. We only have data out to 120 days from the vaccine. Clinically, from actual infection, we've got it out 9 months, but vaccinology wise, 120 days.
Second question, given that some patients are asymptomatic, is there any concern that someone who is infected with the virus gets the vaccine?
So that is how, for both Pfizer and Moderna, some of the exclusion criteria was active or known or past infection. So that is how they had a handful of folks get into the study who ended up being positive for COVID in that 10 to 14 day window. I do think that if they are asymptomatically infected when they get a vaccine, they're probably a little bit more likely to have a side effect from the vaccine. You're hearing about folks that have some good fever, feel a little blah, and I think that probably does go up in folks who are either actively infected or recently infected with COVID, but that's about the extent of it. But that's the frustrating thing about this virus is influenza, you got 24-hour window. When somebody got sick. If they got sick on Tuesday, they got influenza on Monday. We have such a long period with this virus that it makes it so hard to really pinpoint. So I think, again, that might be some people who have a little higher risk of fever, maybe some more myalgias, maybe they take an extra nap or two after the vaccine, but still need to proceed. If somebody has active infection with COVID, they need to be outside of their window of infection. They need to be clinically improved before they get the vaccine. The studies vary, but only about 80% of people who get COVID develop antibodies. In our hospital-based evaluations, we're only seeing antibodies in about 60 to 70% of people with COVID. So again, known infection is not a contraindication to vaccine, but you need to be outside of the 10 days, you need to be clinically improved. And if you had an antibody therapy, bamlanivimab or the Regeneron products or plasma, you need to wait 90 days.
What if they get a symptomatic infection after their first dose? Do you give them their second dose on regular schedule?
Yeah, it's a little harder with Pfizer since you only have 21 days, but they need to be clinically improved and free of fever, not on steroids. If there's not a lot of data on that, but if they did somehow get put on steroids, I'm not sure that I would necessarily vaccinate them while they're actively getting steroids, but that's going to be few and far between in the outpatient setting. But they just need to be clinically improved and no longer contagious before they get it.
And I have one last question. Since I have you on, I'll give it to you. This regards the B117 strain and the CDC recommendations for hand washing, masks, social distancing. Does it make a difference that we have this more contagious strain? Do we think that these hygienic measures will be less effective with this hygienic strain? Or is it really only more contagious for those people who aren't following the rules?
That's a fair question. I don't know. I haven't seen a great amount of data on that. The problem with following the rules, again, there was that study out of Sweden or Switzerland that said masking doesn't work, but they only required masking like 80% of the time. And so you only have to let your guard down when you watch the football game for those 3 hours with your friends. You could be 100% compliant all the other time, but that 3 hours is enough to bite you in the butt. And it's really hard. We see patients, we see healthcare workers who do a great job taking care of their patients, and they go to the break room and they're splitting pizza with people and they're having a retirement party and all that kind of stuff. And so it's so hard to get the true epi data on this because it's really hard to be compliant 100% of the time. So no matter the strain, again, the new Ohio strain and all that kind of stuff, wear your mask, wash your hands, socially distance. And just remember, you let your guard down for your family, for your friends. That's all it could take, and you can end up with COVID.
Thank you, Steve. Very, very good advice. And I think that's a great statement for us to close our conference on. I again want to first thank everybody again for everybody's participation. This was a tremendous amount of work for the task force, for Doctors Miller and Wiam and Anam Hussain, and all of the panelists who took the time to put together these fantastic talks that we had, and to prepare for the panel discussions. We do have a post-survey. That's the pre-survey. We're going to put up the post-survey. There we go. If people would be kind enough to fill out the post-event survey, would be much appreciated. But again, I want to thank everybody on behalf of the Boonshoff School of Medicine, Wright State University, and the Department of Internal Medicine and Neurology. Thank you so much for attending this conference, and thank you for all the hard work that went into it.